Welcome, everybody. This is our next installment of the Hint Summit X live stream, a continuation of the conversation from the last Hint Summit that we had. My name is David Cameron, and I am with my colleague, Dr. Cassandra Workman. We're here to talk about metabolic health today. And before we get going, let's do some introductions. Dr. Workman, would you mind telling me a little bit about who you are, what's your practice, and what's your direct primary care practice like?
Hi, I'm Dr. Cassie Workman. I am a board-certified family medicine doc, and I run a DPC practice, or I don't run the practice. I work in a DPC practice where I have both direct primary care patients and family practice patients, and then I have a specific separate panel that I run that is my eating disorder panel that we call the MEND panel, that gives me the ability to provide specialized care for our eating disorder panel and those patients. And then I can follow them long-term if they move over to my regular panel, if they're recovered and doing well, or I can move them back and forth, but it allows me to provide some different level of care and some more specialized care in terms of our practice.
And my name's David Cameron. And matter of fact, we're in the same practice. We're at Pure Family Medicine, and Cassie is right on the other side of the wall. So we're right next to each other and hopefully don't get any feedback. And I have got a direct primary care practice as well, but I also have a specialty in longevity, which is lifespan, health span medicine. And my patient population is different than Dr. Workman's, primarily because my patients tend to be more on the overnourished side. And Dr. Workman's tend to be more on the undernourished side. And so I don't know if what we're trying to do is kind of meet in the middle, but we're going to talk about different approaches, and our different populations have different needs, and our approach is very different. And so we're going to talk about that and compare and contrast. And then at the end, we'll open it up to some questions. And so we've got a PowerPoint presentation that we'll bring on right now. And, you know, one of the things that I think is fascinating, we'll go to the next slide, is with metabolic dysfunction. It's very prevalent in the United States. And so we're going to be talking more about folks that have an issue with being overnourished. That's kind of a Peter Attia term. I've adopted it, and I think that it fits well. We've got 11% that have diabetes. Approximately 38% have metabolic syndrome. And the criteria for metabolic syndrome, there's a blood pressure greater than 130/85, triglycerides greater than 150, HDL less than 40 for men or less than 50 for women, fasting blood sugar greater than 110, or elevated waist circumference, 40 for men and 35 for women. And you need 3 out of 5 to make the diagnosis. But the risk factors for metabolic syndrome is weight. And so we've got 83% of our adult population that are overweight. And so in some ways, how can we think about metabolic dysfunction? How can we prevent it? So if we go to the next slide, the things that we get worried about with metabolic syndrome is it triples the risk of all-cause mortality and cardiovascular events, heart attack and stroke. It increases the risk of cancer. There's actually 12 cancers that are increased because of metabolic dysfunction, and increases the risk of overall cancer by 18 to 60%, depending on the study. Additionally, many people will refer to Alzheimer's as diabetes type 3 because there is an increased risk of neurodegenerative diseases by about 50 to 70% with metabolic dysfunction, and primarily metabolic syndrome. And so the question is why is that? And so the prevailing theories are that there's an increase in inflammation, cell proliferation, growth factors, IGF-1 and others. And so how can we pick up metabolic dysfunction so that we can prevent metabolic syndrome, how we can prevent diabetes? And so one of the things that we'll take a look at is looking at some of the scales for insulin resistance. So the one I use primarily is the HOMA insulin resistance score. You can also use an NMR lipo profile to also estimate insulin resistance. I like this because our lab, the cash price for a fasting insulin is $15. And so if you take a fasting insulin and you multiply it by the fasting glucose and you divide it by 405, we want that to be under 2. If it's between 2 and 3, that's mild insulin resistance. And if it's over 3, that's severe. Most people are diabetic if the HOMA-IR score is greater than 3. If we take a look at the next slide, we'll take a look at a case. I've got a patient who's a 53-year-old female, no metabolic syndrome. A1C is 5.6, so technically not pre-diabetic. And the BMI was like 25.3. But if you look at her numbers, her fasting insulin was 8.8, and the fasting glucose was 102. If you divide that by 405, the HOMA-IR score is 2.2, which gives her mild insulin resistance. Okay, and so you wouldn't necessarily, if someone, if you're just kind of doing the basic stuff, you might think, oh, okay, you're doing okay. So let's take a look at the next screen. So then the question is what are the other things that we can be looking for? And the first thing I look for is visceral adipose tissue. And so this is the fat that's around the organs. That's not the one that you pinch. It's around the liver, around the pancreas, and the intestines. And so for total fat, goals for men, depends on which paper you're looking at, is typically between 10 and 25% for ideal, and for women 18 to 30%. But if you look at just the visceral adipose tissue or the visceral fat with the centimeter square area, if it's greater than 100 centimeters squared, it increases the risk of heart attack, stroke, diabetes, and cancer. And so let's go to the next screen. So this one right here is showing you how the DEXA body composition, it's one of my favorite ways. I think it's not quite the gold standard, the CT and the MRI, but it's more practical. Whereas this person, I have a hard time seeing this. Is there any way to blow this up a little bit? But if you look at the percent fat, it's around 21.7. And so it would, and this is for a female, so it'd be roughly in the right ballpark. But if you look at the visceral fat, which is down at the very bottom, the VAT area squared, it's 131. And so it's above 100. So this person has more inflammation because of that visceral fat, and it puts them at risk for heart attack, stroke, diabetes, and cancer. So let's take a look at the next slide. So question is well, what else can we be looking at? And so many times people have a continuous glucose monitor if they're diabetic. I have been using this more to take a look at what their blood sugars are doing and identifying if patients will have an elevated fasting blood sugar or if their blood sugars are elevated after eating. And so fasting blood sugars, we want them to be under 100. And then postprandials, we want them to stay under 140. And the cost for this is about $160 without any insurance. A lot of times insurance will cut that in half for a month's supply for getting 2 sensors. But if you take a look at this patient, she's got some, I'll go back one screen. So if you take a look at the fasting blood sugars, they're 107, 97, 101. So they're kind of borderline. And then after this person had a sausage burger with some sweet potato fries, the sugar went up to 178. Coffee and cream, it didn't really change too much. And then later on with meatballs with meatloaf with cabbage, and then some peach crisp with homemade whipped cream made with stevia, it didn't really change the marker too much. Patients really learn a lot. I'm a big believer of the Hawthorne effect, where if you measure things, behaviors change. And so I have people do this, and then people learn a lot about how they process food. So we'll take a look at the next slide. Another thing we look at is doing a VO2 test. And a VO2 max is where people go on a treadmill or a bike, have got a mask strapped over their face, and then we'll measure how much oxygen they're consuming and how much CO2 they're producing. So the blue line is the heart rate. The red line is how much CO2 is being produced. And then the yellow line is the VO2 max. And so over time, around the 11-minute mark, we reach the max VO2, which is around 32%, which is about the 50th percentile for this patient. And there is a line where the CO2 and the O2 cross. That's where she starts getting into the anaerobic stage. And then as it starts dropping back down again, that is in the recovery phase. So if you go to the next screen, you can calculate the calories of fat and the calories of carbohydrate that are burned. And so one of the things, you look at this, if the blue bar is the fat calories and the yellow bars are the carbohydrate calories. And then the heart rate starts at 113 all the way up to 167. And so you notice that the most amount of fat burning is at 113. It's a lot lower. It takes a lot longer to burn fat than it does to burn carbohydrate. And so as the level of exercise goes up, as we start going from zone 2 to 3, 4, and 5, then there's less fat burning and there's more carbohydrate burning because the carbohydrates are much quicker energy. So one of the things I chat with my patients about is finding their place where they can burn that visceral fat the most effectively. And so for this person, she started training around the 113 to 117, getting her heart rate around there. And that's where she really started to lose weight. She was training and trying to lose weight because she was in much higher heart rates. She was trying to do too much, and she found it wasn't very effective. Let's go to the next slide. And so for my patients, we take a look at a lot of data, and some of this is aspirational for some patients, but sometimes we work up to this, but I'll try to get them up to about 4 hours of cardio per week, where 80% of that is in zone 2, targeted towards their goals for what their weight loss goals are. I also get them on some strength training. We didn't talk about muscle mass too much in this topic, but one thing that we're trying to do is to also increase their muscle. The order in which you eat is very helpful in the glucose rise. So if you eat the fiber first, that layers a matrix of fiber in the intestines, and it makes it more difficult to absorb carbohydrates. And then proteins tend to slow down the gut. And so there's a slower absorption of the carbohydrates, and then having the carbohydrates last. So just the pure order of the way that people eat can help slow the absorption of glucose. And the other is protein targets. Now there's some debate about kidneys. I'm not particularly, I find that most patients do not have to be on a low protein diet, even if they've got mild kidney disease. So I know Peter Attia is a big fan of higher protein targets, about 0.8 to 1 gram per day per pound of ideal body weight. And most of my patients are very successful when they have higher protein targets, because that's quite a bit of protein. And then complementing that with a fiber target of about 25 grams per day, while also limiting processed foods and drinks. And so I spent a lot of time discussing some of these recommendations and looking at the data and using the Hawthorne effect to try to help our patients get to their metabolic goals. Now we're going to transition to a very different patient population, and you'll see we're going to compare and contrast some different strategies, and you're going to notice that Dr. Workman has a very different approach because of the different needs for her patient population. So Dr. Workman, take it away.
Thanks so much. So when we talk about metabolic health, which was so interesting, I appreciate Dr. Cameron sharing all of that. Eating disorder is a whole different animal, and definitely this is metabolic dysfunction that we can compare and contrast a little bit. But in many ways, a lot of the information, the data that is super helpful in kind of our overnourished population and trying to hone in on those goals are really, really tough with the eating disorders. And so in some ways, this is when you have to kind of leave the data at the door and actually do a lot more emphasis on your history and physical. So from an eating disorder perspective, there's a 9% lifetime incidence of eating disorder. And this includes many diagnoses. This can be anorexia, bulimia, binge eating disorder, and ARFID, which is kind of the newer kid on the block. There's also OSFED that I didn't put through there. ARFID is kind of your sensory kiddos, generally speaking, in terms of stereotypically, that have trouble with certain textures or certain foods that has nothing to do with their body image and everything to do with having fears about eating or eating specific textures. OSFED is kind of the other specified eating disorders, it doesn't fit in the category. So they may not fit all the criteria. And when you talk about eating disorders, it's hard to find a good general definition because they can be so different in how they present. So somebody who has anorexia restricting type is going to look very different than somebody who has a binge eating disorder, although you could also argue that they all have very unique and disordered ways of thinking about food and how they nourish their bodies. Majority of these patients are not underweight, which means that you have to have a really high index of suspicion rather than looking at the data. And then sometimes the data can actually lead you the wrong way. And we have to be really thoughtful about what does that dysfunction looks like in somebody who's undernourished. But I like to think about what is their relationship with food, with exercise, and even control. Many times this can be related to control, trying to control either their bodies or just other things in their lifetime. So let's go to the next slide. And one good screening test that can be kind of for the classic eating disorders, and this is generally speaking in adolescents and adults, but this one specifically more for adults, is a SCOFF screening. And this is actually comes from our British colleagues, which is why you're going to hear the 1 stone in here, which it looks like I've changed it. So do you make yourself sick after you feel uncomfortably full? Do you worry that you've lost control over how much you're eating? Have you recently lost over 6 kilograms? And they'd say 1 stone. In a 3-month period, do you believe yourself to be fat when others say that you are too thin? And would you believe that food dominates your life? This is just a quick screening that anybody could do in their practice. 1 point for every yes, and a score that's greater or equal to than 2 likely means a case of an eating disorder. But I would say it's very nuanced. And most of my patients, even today, I had a patient who's quite ill that says, I just don't believe that I have an eating disorder. But the fact that she's very bothered by the fact that she ate a chip or that she ate anything yesterday definitely gives you a high index of suspicion. And also remind yourself that these things are generally kept secret. So it's kind of hard to get after them. So again, a high index of suspicion with a lot of that history. Let's go to the next slide. Here's where the data sometimes shoots you in the foot. And so as much as we as physicians and also our patients, I saw something recently that drawing labs to a patient means that we heard them. And not to say that I don't draw labs, I do. You can check a blood count, thyroid, liver, kidney, phosphorus, magnesium. Celiac panel is recommended in kids with anyone who's losing weight because that person could be eating just fine. And actually it's celiac. It has nothing to do with an eating disorder. But I expect all these to be normal, especially in my patients who have anorexia. Our body is fantastic at maintaining homeostasis, and patients can be really, really sick and still have quite normal labs. I do have a high suspicion of an eating disorder if somebody's coming back with a low potassium or a low glucose without really any other causes. That would put my antenna up to think about it in terms of, is this person purging? But if they're not purging and they're just restricting, these can be quite normal. The other thing that can make you crazy is that you can draw a lipid panel on that, and many of my patients do, and their cholesterol is actually high, their LDL is high. And we're not exactly certain all of the mechanisms of these, but it's interesting when you weight restore them or actually get their nutrition to a better spot, their cholesterol officially drops. So unfortunately, many of these people will go in and talk to their doctors and they say, I'm worried about my eating, it's not normal, or I'm feeling compulsive about things, or I'm feeling really out of whack on things. And patients will get labs drawn and then their cholesterol drawn, and the patients will get then feedback because we're in a hurry that says, hey, your labs are normal except for your cholesterol. You should probably eat healthier and work out more, which is exactly the opposite of what they need. We don't do body composition in this population. It would likely spin them out. They don't want to see it. I can't tell you how many times people have been quite cachectic and emaciated, and they still don't have the 6-pack abs they're looking at, but they're also losing muscle mass with all of these. So a body composition would really mess them up in this. The one caveat on that is we do recommend DEXA scans. If anyone's not had a period in more than 6 months, or if they've had an eating disorder, has had disorder eating for over a year, then we want to look at that bone density. And this is one what I love because the data here actually does help me. I can go to somebody and say, look, you think that you're healthy because you are an athlete and you're taking care of yourself and doing all the quote unquote things, eating only clean, being really restrictive and things like that. And look, your bone density is actually dropping from what we expect it to be. So we can see patients that are low body weighted or just have been in a disordered place where their bone density will be off and they'll have osteopenia or osteoporosis during that time. So that's one that the data does help me, but I would say normal labs in this population does not help me. In fact, I'm really concerned if their labs are coming back abnormal. We may see in very sick patients that they may have elevations in their liver enzymes. This is not fatty liver. It's kind of like your liver putting out distress signals. So this is just a different kind of measurement in terms of dysfunction. Let's go ahead to the next slide. So if we're talking about the diagnostics and the labs don't help, what does help? And I would say history is huge on this. Also getting other people to come in and talk to us about our history, especially in teenagers, if they're not going to be very honest about what they're eating. Their parents may have seen what they were, what else is going on, or partners and then more of an adult population can be helpful. Vitals can help you with clues on this. So a pretty classic one in somebody who's undernourished is that they will come in and their heart rate will look normal or even a little bit on the high side, just coming in how we do our vitals in American practice is that, come in, sit down, get your vitals. It's pretty quick from that move to the waiting room into a room to get your vitals done. And their heart rate may be normal or even a little bit high. When you actually get them in a resting state, and we commonly get EKGs to make sure that everything looks good on that, you'll see that their heart rate's pretty low, can be in the 50s. And a lot of people will come to me and say, but I'm exercising a lot, it's because of that. But the difference is somebody who's very well trained in terms of exercise, their heart rate won't go up just coming from the waiting room into the room. So that would be more stable in somebody who's more athletic versus a malnourished heart. So that can be helpful. Blood pressure can be low, but I'm big on what's the function? What is the function and what is the flexibility in terms of their eating and their exercise? So what are they eating? When? How much? How do they feel about it? What is their relationship with exercise? Are they out? I had a patient that was outpacing in terms of walking her golden doodle. And we thought, well, gosh, that's a high energy dog. If your dog's getting tired on your walks, you may be overdoing it. Missed periods can be helpful in somebody who is born female in terms of if your periods are going away, we need to look at what that looks like, but also just how they're feeling, their dizziness, headaches, what their concentration is, when was the last time they pooped, having a racing heart just with very little activity. All of these look at the function of a patient and can give you clues that they're probably in a malnourished state. Let's go ahead to the next one. Treatment in terms of this is very much team-based because this is a hard thing that there's a lot of medical and psychological overlays. So getting them in to see a dietitian, it looks like I repeated myself there, a dietitian, registered dietitian, not somebody who just has their, a nutrition certificate from a 6-week class. Seeing a physician, seeing a psychiatry. The one I missed on here is therapist, which is huge in terms of thinking about it. I think up next we have a case to just kind of explain this. So this is pretty typical for me. I'll see a 28-year-old female who was feeling fatigued, stressed, anxious after a recent breakup. She's just not feeling herself. And so what many people will think, okay, well, I'm just going to do a better job of taking care of myself. So I'm going to clean up my eating and cut out all the bad stuff. And I'm going to join a gym, and found that she was losing some weight, maybe had some people telling her like, hey, you look so great, this is awesome. But she's also realizing some increase in GI symptoms, like maybe abdominal pain. She may be having some early satiety, some constipation. So her friend in the best recommendations would say, hey, let's talk to a functional medicine doc. That's a pretty common thing before they come to see me, or they'll go see their regular doctor and feel dismissed because their labs are normal and their cholesterol was slightly elevated. So they just sent them on their way. So this functional medicine practitioner did a battery of tests and recommended she cut out gluten, dairy, sugar, start a low-use diet, all of the standard, like low inflammatory, do this. But what's the problem is that because this person is already malnourished and getting undernourished, her GI system is not operating at its best. And so what we're actually doing is perpetuating issues here. So she will actually, generally speaking, find that her stomach issues are only worsened. And she'll realize she doesn't have the energy for her workouts. Friends start to worry about her health and her weight. Her periods become irregular. And this is when they'll land in my office and many times say, there's nothing wrong with me. I don't have an eating disorder. I was just taking good care of myself. But you can see in this patient, her function is really what's trying to struggle. And the labs are really not going to help me as much as how I can focus in on. Let's normalize some of your eating. Let's get some of your intake back. Let's normalize some of the relationship that you have with it. And that's when we're going to see maybe your GI symptoms get worse at first because we're pushing on that system, but they might get better over time. And I've actually had patients that have come back and said, you know what, once I've been able to weight restore and have a normal relationship with food and things like this, they're not thinking about food. They're not getting worried about it. And they can go back to having more of a balanced lifestyle and getting back into exercise and things like that. But it is a long process. So that's a little bit of how we look at that. Should we look through?
Here's a question from Jamie about semaglutide. I think this would be an interesting question to address. It says, for knowledgeable patients with mild, or here we go, disordered eating, would semaglutide be used at low doses in the right place to improve food, thought, etc.?
So I think that this is something that's still hotly debated, and I don't know that we have the evidence for it. In my practice, I'd probably reach more for if they're stuck on the binging side of things and lack of control. I would actually get them with a dietitian and a therapist. I would normalize their eating during the day. Many of our binge eaters, in an effort to reduce weight, are not eating all day long and then they binge at night. So they actually probably need to eat more throughout the day to decrease their binging in the evening, because they kind of get in this feast or famine mode. And so if they can work through some of the therapeutics on that and the dietitians, and in this case, I actually would probably use something more like Vyvanse that's been FDA approved for binging, rather than the semaglutide, even in a low level. My concern about calming down the food noise in this patient is that if their binging is kind of related to the fact that they're not getting well nourished throughout the day, the binging could actually go worse with semaglutide, or then they have worsening gastroparesis. So it is definitely something that people are looking at. In my practice, I'd probably reach for the Vyvanse first.
Got it. Hey, question for you about missed periods. It's very common for female athletes to start missing periods. When are you worried? When do you check labs? When should someone like myself think about referring?
Well, that's a great question. If you look at the literature, most coaches, like the traditional stuff, will say like a third of runners are going to lose their periods. There's some good evidence to say that if they're losing their period, they're losing bone. And so if they're losing their period, they should probably look at increasing their intake. They're probably in a relative energy deficit, and that they should probably start looking about that within 1 or 2 missed periods. Now, doing labs and things like that, I think, can be helpful to make sure it's not thyroid and it's not other things that are related. But generally speaking, they're not going to be as helpful. And I would argue that any female that's losing her period with exercise should probably increase her intake or cut back on the exercise and see if that makes it simple. The hard part in this situation is some of those, that's the early start for the eating disorder, that slippery slope down, and they're just going to lose it and never get it back because they just find, oh, I'm running faster because I'm lower weighted and periods suck anyway. So what do I care? But that really is a red flag that I would say most people, if they've missed a couple periods in a row, they probably need to increase their intake, especially if they've increased their training. So it's a great question.
In addition to thyroid, do you look at LH, FSH, estradiol, progesterone?
Yeah, that's on the list of things. I just don't find it super helpful. And a lot of them can come back normal. We know that can be really tricky. I think it's also tricky in like the perimenopausal space of things, of like so many of the information that we're hearing is take better care of yourself, right? But if they're slipping into that where their nutrition isn't enough, they could be having some abnormal periods related to that isn't anything to do with perimenopause, right? So I think it's a really tricky thing, and that's where I think your interview makes a big difference.
Okay.
Yeah.
How do you think about what does success look like for you? Like,
that's great.
What would you say would be your treatment goals, or how do you even think about that? How do you approach that?
So I think because we talked about how metabolic dysfunction in this group looks at their function, how they're functioning throughout their day. But also I think that where they're at in terms of their relationship with food and exercise is a huge thing. So there's a lot of having to be honest about how you felt about increasing things, having flexibility. Were you okay to go out with your friends and just order whatever they ordered and you got to eat with it? Were you able to have regular bowel movements? Is your heart rate looking good? And that can be based, honestly, like target goals in terms of weight restoration or even where you're at. That can be based on past growth curves or even an ideal body weight to make sure that you get kind of close to that goal. But it looks at function. It looks like how you're showing up in the world. I imagine for you, though, what does success look like for you? What is going to be your end goal in terms of success for these patients?
Yeah, and it's different depending. I always ask my patients what their goals and their values are.
Yeah.
And so I first will tell them based on data that if we get your visceral fat area to be below 100 centimeters squared, it's going to decrease the risk of heart attack, stroke, diabetes, and cancer. We know that for sure. But sometimes their goals are going to be different. And so I think I can use a DEXA scan, and where I saw a patient yesterday where her visceral fat was at 80, but her percent fat was at 35. And she didn't feel really great in her clothes, and she wanted to put on some more muscle. And so we had a different target for her, for her energy intake, her protein intake, for exercise. We started doing some strength training. We did VO2. And so we're going to target that differently. But I would say if they're in the range of normal for percent fat, that if they're in the range under 100 for visceral fat, I'm feeling a lot more comfortable. And then I love increasing muscle mass. And so so the other thing, with the DEXA scan, really just the DEXA body composition scan, which is different than the bone scan. It does take a look at it'll take a look at bones, take a look at muscle, and a look at the fat. The bones is not quite as accurate as doing the bone scan, but it's a good approximation. And ours, it's only $99 in the Denver metro area, which I actually like because it's affordable. And so, a lot of times I've got some people that come in, they've got BMIs, that are 30, but their fat and fat is at goal, and they wanting to put on some more muscle. And I'm like, okay, so I don't really use BMI much anymore. So we get it because the EMR will have a BMI, but it's not particularly helpful for my patient population. Do you find the BMI is helpful?
Not necessarily, no. I mean, I have patients that their BMIs are normal and they're quite ill and they're going to need a lot of additional support. It just depends on where they've been. I've seen a patient where he lost 100 pounds because he was trying to get himself into a healthy routine, but probably lost it too quickly, dropped out his testosterone. He couldn't think clearly, all of the things. And this is somebody who, was eating healthier, lost 100 pounds, went from 300 to 200, but the way that he functioned in the world was pretty disordered. He couldn't think through things. He couldn't show up to work, all of those things. He ended up in eating disorder treatment, and his BMI probably would still be too high. So agreed. Yeah. The BMI doesn't give you as much. Yeah. There is another question that I think that is probably up your alley over here. Just curious from Jamie as well. Just curious if you have any evidence or advice with NAD.
Okay.
Yeah. So I think take that one away. That's in your wheelhouse.
So NAD plus is an enzyme. I mean, this is going back to high school biology. It's an enzyme in the Krebs cycle. So glucose and oxygen goes through the Krebs cycle to produce 32 ATP, but it's NAD, and NAD plus goes back and forth to shuttle to make your ATP. And so as we age, NAD tends to drop. We see a lot of people that get sick, that get COVID, that get the flu, and their NAD levels drop as well. Now, the question is, we want NAD levels in the mitochondria. Now, how accurate are blood level NADs comparison to mitochondrial levels? Nobody knows. And so there's been a few different attempts to try to supplement NAD. Some people will do the precursors, either NR or NMN, which are the precursor. Two NMNs put together make NAD, and those are absorbed. And there's been some studies that show that if you take NR and NMN, it does increase the NAD levels in the blood. However, if you take NAD orally, it's not absorbed. It's too big of a molecule. It doesn't get absorbed. And so to really supplement NAD, you got to either do an infusion, an IV infusion. We don't do that in our clinic, but we do sub-Q NAD infusions. And so I just have people that come in, we give them a vial. The vials from our compounding pharmacy are about $135. They got to keep it on ice. So it's not terribly expensive. And it comes, the ones that we get come in 500 milligrams. And so typically we'll do 50 to 100 milligrams per sub-Q injection. And I'll tell you, I tried it myself. I didn't have any fatigue or any low energy, but I felt wired. Like I just did 50 milligrams. And I think I'm a little more sensitive than most, but I felt like I had 3 cups of coffee and I felt like my heart,
well, and Dave, you on a good day, you're already pretty energetic. I can't imagine you extra boosted.
But you know what? A guy named Craig Conover, I listened to his podcast, and he does a lot of this. And looking at good quality studies, I haven't found a whole lot of good quality studies that are randomized controlled studies comparing those that get NAD infusions or injections versus those that haven't and how they're doing over time. But I think more of it is kind of expert opinion, anecdotal. I think the studies for safety are pretty good, but there's quite a few people that have had chronic fatigue that had benefit in our practice and from Dr. Conover. I've had some people that have tried it and said, nope, didn't help at all. I would say probably it's about a 50% hit rate in our practice. And so I oftentimes give it a try. And tell people you don't. And I usually start off I start like at 25 milligrams for the first test dose, just in case someone's really sensitive like me, and then ramp it up to either 50 or 100 milligrams per injection. And then I train them, and then I'll have them do the rest of them at home.
Mm-hmm.
So
awesome.
Here's another one. In your DPC practice, do you utilize health coaches, and if so, what does that look like?
So I do not use health coaches. I do use a team. So most of my patients are seeing a dietitian and a therapist, usually weekly. And then they see me once a month, and then we coordinate care. So I'm constantly emailing back and forth with my team in terms of that. Although we have seen some patients do really well with eating disorder coaches, and those coaches actually can do things that one of my patients said that they were pleasantly annoying. So texting and saying, what did you have for breakfast this morning? And what are you going to have for lunch? And doing those things to kind of keep eating forefront of their for their things. I could see that using that a little bit more. In the eating disorder space, I really be careful that I need people to be very educated and not sneak into too much of the pseudoscience or anything that could probably layer on actually more difficulty with my patients, because they already have enough of the orthorexia, got to be super healthy, like arguing with me in terms of like, you're telling me to stop exercising and that can't possibly be healthy, even though we have studies to support that that's actually harmful for their bones if they're underweight. So I think in my situation, I have to be really careful about who we pick, but I do think support is helpful. What about you, Dave?
Well, I love data. And one of the things that I have been finding is that getting more data for my patients, I've utilized less health coaches, partly because patients end up coaching themselves. Like with a continuous glucose monitor, frankly, I don't necessarily coach them on it. I give them a few general principles and I say, experiment and have fun, and then tell me what you've learned. And then they come back and they go, wow, I had no idea what rice would do to me. Like my blood sugar goes up to 180, if I eat rice by itself. And then they'll tell me, but wow, I did all of these other things and it helped my blood sugar stay more even. And I feel so much better because I don't have these big spikes and then drops. Because a lot of times people feel tired in the afternoon because they get a big spike in their sugar and then they get a big insulin surge and then their blood sugar drops and then they feel really tired around 2 to 3 o'clock in the afternoon after lunch. And then they start working on what they're eating. And once they start getting that leveled out, they go, wow, I feel my energy level is stable throughout the day. And so I'm happy. I work with nutritionists. I work with athletic trainers and stuff. But that being said, I love getting a VO2 max and I have them put together their own plan. I actually give them a sheet of paper with all the questions and I have them build their own exercise, nutrition, sleep, and their kind of mental health, kind of stress management plan. And then we talk about it. And frankly, we do a lot of it ourselves. And I think it's super fun.
Well, and I think and imagine too that patients have better buy-in when it's something that they're doing and they have, this is something that's easy for me to incorporate, or this is something that's an improvement, like a 5% improvement that I really actually think I can do, rather than you prescribing something that wouldn't fit into their life.
Right. Well, you know what? I kind of think, and I don't know how you think about things, but I think people have estate planners so they can figure out how much money they want to have when they're in their 60s, 70s, 80s, 90s, and 100s. I kind of think of myself as being kind of a health planner. Like, what do you want to do? How do you want to live your life? And how can I help you meet your goals when you're 70, 80, 90, and 100, so that you can be able to do the activities, be able to take the suitcase and put it in the overhead bin in the airplane, to be able to pick up grandkids, to be able to, walk 3 miles. What are the things that you want to do? And let's, like a marathoner is training for a marathon, let's train to do those activities. And so that's how I think about things.
I love that. And I think the problem with my patients is that they want to do all those things, but they don't understand what they're doing will not get them there. And that's going to shoot themselves in the foot. So it takes a lot of exercise in terms of thinking through, mental exercises in terms of thinking them through. What they're doing is not actually going to get them to that goal. And so that's a backwards approach.
Is that a motivational interviewing tactic, or is it more of a specific kind of counseling style that you do to help reframe things so they can think about things differently?
Yeah, I think motivational interviewing for sure is part of it, but also it depends on the patient. I mean, I have so many patients that I'll ask them, what % of you wants to actually get better from your eating disorder? And you'd be, maybe not amazed, but there's a ton of people that come in that less than 5% of them wants to get better. It's their family that made them come. They want to hold on to that eating disorder because it makes them feel safe and they feel like they're doing the right thing. So I think it just depends on each individual person, because if we focus on what do you want to do down the line, it takes a lot of work to let them understand that they're not even going to get to that goal. And so much of their day is so consumed with food and thinking about the food that they're not eating, or thinking about the food that they're going to eat and then purge, like that so much of the future casting is hard for them. So it's a little bit different in terms of thinking through those things.
Yeah. Mm-hmm. Any last parting thoughts before we finish up?
Well, I'm sure that Hint would love us to say that adding extra tracks to our DPC practice, I think you would probably agree, I agree, has been really refreshing in terms of being able to add extra ways that we can provide care to our patients. It also breaks up the day and makes it more interesting, and gives you a little bit of fun, something else to look into. And so I think figuring out what you're passionate about and being able to kind of lean into that a little bit more to provide extra care for our patients has always been helpful. I think that's been my experience. I think that's yours as well. Yeah.
And I've actually been surprised because some of this stuff is not very expensive, because a lot of times insurance won't cover any of these things. Like a fasting insulin lab is $15. A DEXA body composition is $99 here in Denver metro area. Doing a VO2 max, we've got 3 places that we do most of our referrals, and it's between $200 and $250. It's not a very fun. I've done them 3 times now. They're not very fun because you get worked till you fail and you've got a mask on. So you got the claustrophobia and all that stuff going on. And then continuous glucose monitors, depending on if insurance might cover a little bit. I think with GoodRx, it's about $160. So I think you can do a lot of this stuff for about $400 out of pocket. And frankly, these are things that any direct primary care practice can add. And I just started doing it. And I mean, I listened to podcasts, I listened to Peter Attia Huberman, and just started adding these things to my practice. And one thing that we do, since we do have specialties, we do have a different price point for those. And I think that has been something that has been able to reimburse us, because it definitely takes more time. We spend a lot of time counseling our patients. And I would say it's in the order of 3 times as much time as a standard direct primary care practice. Would you say that's about accurate?
We use a multiplier for eating disorders as 4.5 times.
4.5 times.
Yeah. And that's there are some extra questions popping up that kind of go along with this in terms of extra services. You and I both, these are not included in our regular DPC memberships. This is something that we are doing as an additional cost, either an add-on or patients are signing up specifically for that in our practice. So we have different pricing for that. So yeah, it's not something that we just offer. I think there are some certain spinoffs. It's like if a patient came to me and just wanted to do, they just wanted to do a continuous glucose monitor, things like that. That's part of our DPC practice. But these additional, like having kind of the overhaul and really getting the good care is additional costs.
Yeah. And about DEXA body composition and VO2 max, are they done offsite or my office? Offsite. So frankly, we don't sell anything. We want to try and be as independent as possible. And so we got a few different places that do VO2 max. My favorite is a direct specialty cardiologist in town.
He's
His
awesome.
office is in a gym, and he does echoes, but he only takes cash for and so I love working with him because he can also give them cardiology advice. But we do have a performance athletic training center, and then another individual that does them as well. But I sometimes, depending on what the patient wants, if someone is really a high performance athlete, I'll usually have them go to the high performance athletic trainer. But if it's more for kind of general VO2 max and longevity, usually the cardiologist. And I love independent freestanding radiology centers, and that's where we get our best pricing. So locally, we've got a couple of those, and we can take our pick. I definitely would not send them to a hospital system for this, because you're going to have to pay facility fees and other costs that go along with that. But we get really good pricing and high quality from our independent freestanding radiology center, and we got a good relationship. I actually know the radiologist over time because I think I'm probably the person that orders the most DEXA body composition studies. And so the two of us, like a couple of times, I've been confused by the calculations for the lean mass indices because they're kind of confusing. And by the way, when you do a body composition, you get a lot of data. There's a lot of numbers that you get. And it took me a while before I kind of figured out how to weed through these things. And chatting with your radiologist who reads them can be really helpful in being able to understand the data well.
Mm-hmm. Yep.
Let's give a plug. The HINT Summit is going to be in combination with Health Rosetta Fest, and it's going to be August 24th through August 27th this year, and it's going to be in Denver. There's also going to be a dedicated direct primary care track, and we are really excited for that. You can get your tickets for that at rosettafest:/summit.hint.com, and so really looking forward to continue the conversation and having a whole lot about practice management and more clinical content there. Okay. Well, Dr. Workman, thank you so much for your time and your expertise.
Thank you.
Have a great day, everybody.
Thanks, guys.
Bye-bye.